Hello and welcome to PrimeLogic CE's presentation on COVID-19, the illness that leaves us thinking. My name is Robert Moya. I'm a critical care paramedic and licensed paramedic. I've been an educator for over 15 years and have been providing emergency medicine for over 25 years. Throughout this pandemic, I have been actively involved in reviewing facilities with outbreaks of COVID-19. I have deployed teams throughout the region to assist in hotspots of COVID-19. I've also provided direct patient care, patient testing, as well as medical control for various agencies throughout the region. Throughout this time, I made it a point to become very informed on SARS-CoV-2, COVID-19, and how it affects the body and how it affects the responders that help patients with COVID-19. As a result, I aggregated numerous studies, information, current evidence-based medicine, and feel that I should share that with the rest of you guys now. One of the things I noticed throughout this research and studying is that a lot of the information wasn't really broken down in easy information that we could understand. From the doctor level to the nurse level to the paramedic, RN, LVN, CNA level. So I hope that this presentation will make things a lot easier and allow you to understand SARS-CoV-2, the coronavirus, and COVID-19 better. After completing this presentation, you'll be able to understand the physiology of SARS-CoV virus. You'll be able to identify the pathophysiology of COVID-19, identify the mode of transmission for SARS-CoV-2, understand how infection rate is determined, list the appropriate infection control measures, list the signs and symptoms of COVID-19, understand testing procedures for COVID-19, and also be able to discuss the treatment for COVID-19. We will also discuss the use of antivirals and steroids in the treatment of COVID-19. At the beginning of my research, I learned that we have been using the terminology COVID-19, coronavirus, SARS coronavirus interchangeably. We need to learn that the SARS-CoV-2 is the virus itself. COVID-19 is the clinical illness that results from the coronavirus. SARS-CoV-2 is part of the coronavirus family, but is most closely related to SARS. The coronavirus family includes 6 types. It includes 2 alpha coronaviruses, 2 beta coronaviruses, all 4 of which will cause and is most closely associated with the common cold. At some point in our lives, we have all been exposed to a form of coronavirus. The next coronavirus is the MERS-CoV that causes MERS, or Middle East Respiratory Syndrome. The last one is SARS-CoV that causes SARS, or a severe acute respiratory syndrome. Again, this is a family of 6 coronaviruses. Once again, COVID or SARS-CoV-2 is most related to SARS. The virus binds itself to type 2 alveolar cells, intestinal epithelia, and vascular endothelium. These are the same receptor sites that SARS binds to. The virulence and the transmission will shift over times in ways which we currently cannot predict. For the ease of this presentation, I will now start using the term COVID-19 to refer to both the illness and the virus. COVID-19 affects the body systems in a variety of ways with no discernible pattern. But we have been able to determine 3 real responses in the body as a result of COVID-19. One of the first responses is hypoxemic respiratory failure. The virus will reduce surfactant levels in the alveoli. This causes atelectasis or collapse of the alveoli and causes something called de-recruitment. This is the failure of the lungs to be fully aerated. Another thing that the virus does in the lungs is that it will actually attack pulmonary cells and cause them to have structural changes. This is implying that there is direct virus damage to pulmonary cells as a result of COVID-19. The next type of response is a cytokine storm or a hyperinflammatory response. Evidence is suggesting that most patients may respond to COVID-19 with an exaggerated inflammatory response. If you're familiar with that term, it's SIRS. Symptoms kind of go from one extreme to the other. They include fever, they include fatigue, loss of appetite, muscle and joint pain, nausea, vomiting, diarrhea, rashes, fast breathing, a rapid heartbeat, low blood pressure, sometimes seizures, headaches, confusion, delirium, hallucinations, tremors, loss of coordination. The signs and symptoms are sometimes endless when it comes to this. The next thing that we've noticed that emerging science has taught us is that COVID-19 is actually causing disseminated intravascular coagulation, or DIC, in its patients. If you remember, DIC is basically hypercoagulopathy, likely due to systemic inflammation and direct vascular endothelial injury caused by the virus. In a lot of the lab studies on patients with COVID-19, they've noticed elevations in fibrinogen and D-dimer levels, eventually leading to multi-organ dysfunction syndrome, or MODS. As I've said before, COVID-19 is no joke. Many of you that know me have heard me say it. It's like rolling some dice in Vegas. Are you going to get the sniffles, or are you going to wind up on a ventilator in a prone position close to death? In order for us to fully understand our COVID-19 patients, we need to fully understand the stages of the illness. Stage number 1 is the early infection stage. Incubation is followed by non-specific symptoms, usually general malaise, fever, a dry cough. This phase may last for several days with fairly mild symptoms. Patients often don't require hospital admission at this point. A lot of them will actually self-quarantine, hopefully at home. Biologically in the body, viral replication is occurring. An innate immune response follows, but this fails to contain the virus. Symptoms reflect a combination of direct viral effect on host cells and innate immune responses. We then progress to stage 2, the pulmonary phase. Despite being stable for several days during stage 1, the patient now starts to enter stage 2, and they may abruptly deteriorate, often with worsening hypoxemic respiratory failure. These patients will often present to the hospital at this point or call 911. Potentially stage 2 and this hypoxemic respiratory failure may progress rapidly to ARDS, or acute respiratory distress syndrome, and require an intubation. Systemic inflammation labs are often moderately elevated, i.e. C-reactive protein, ferritin levels. Biologically, the patient is having an adaptive immune response that is occurring right now. This causes a reduction in viral load. Yes, you heard right. The viral load has now been reduced. Unfortunately, this also leads to increased levels of inflammation and tissue damage. As the patient continues to get worse, they now progress to stage 3, or the hyperinflammation phase, otherwise known as the cytokine storm. The patients deteriorate with progressive DIC and multi-organ failure. You'll start seeing these patients start going into vasodilatory shock, cardiogenic shock. Potentially, some of these patients will also start going into a septic shock of some sort. You also will start seeing myocarditis and endocarditis in these patients. The patient may initially respond well to intubation and ventilation during stage 2, but subsequently develops increasing levels of inflammation, which lead to clinical deterioration. A perfect example of this was the case of a 62-year-old female that called 911 on a Thursday mid-afternoon. She was transported to a hospital. By Friday, her respiratory status had gotten worse. She became severely hypoxic, and a decision was made to intubate her. The patient remained intubated going into Sunday. Sunday, she actually started to show marked improvement to where the doctors were actually talking about extubating her. Unfortunately, early Monday morning, late Sunday night, the patient went into sudden cardiac arrest and died. This is just indicative of how quickly this virus and this disease can progress. One of the things in stage 3 that we have to look at is that there's an adaptive immune response that starts to spiral into an immunopathological dysregulated cytokine storm. So the question that always comes up is, how do we get exposed to the coronavirus? Various studies, various research has shown that COVID-19 can occur via large droplet transmission. Some evidence, recent evidence, is now suggesting that it can actually be transmitted via airborne route, which means that small particles will remain aloft in the air for longer periods of time, thus exposing you to the virus. Another way to acquire the virus is by transmission on surfaces. Studies have shown that droplets will settle on surfaces in a room, create a thin film of coronavirus, sometimes up to 4 days, thus allowing the potential for you to be exposed. Studies have also shown that the virus may be shed in nasal secretions as well that can be transmitted to the environment. So I want to use an example. You're preparing a meal, you realize that you're out of hamburger meat. You drive to the local grocery store, you place your mask on, you put some hand sanitizer in your hands, you walk into the store. While you're there, you realize I'm out of lettuce, I'm also out of some tomatoes, but I definitely need hamburger meat. You go through, you select the lettuce, you select the tomatoes, you weigh the tomatoes on the scale, you punch in the number so you could get the label for the tomatoes. You walk over to the meat market, you get your hamburger meat. While doing this, your phone rings, you pick up your phone, you lower your mask, you put the phone up to your ear so you can have a conversation. You then walk over to the cash register, you put the phone away, you pay for your meals or for your products, you walk out the stores, you're walking out, you remove your mask, and all the sweat that's on your face from the mask, you decide to swipe off or wipe off with your hands. You enter your car, you go home. Unbeknownst to you, prior to you touching that package of hamburger meat, there was a person that walked up, sneezed into their hand by pulling their mask up. They wiped their hands on their pants. They walked over, grabbed the same hamburger meat package that you have now gotten later on, and you walked away with it. What is the possibility of you acquiring coronavirus or COVID-19 from the transmission of that surface? Remember, you picked up the same hamburger meat that was touched by someone else that had potentially shed nasal secretions into their hands. You walked out the store, you removed your mask, and then you wiped your face. I want everybody to just kind of think about that and really put some thinking into that whole situation. COVID-19 incubation has a median of about 4 days with a range up to 14 days. That is a long range for incubation. Transmission appears to occur over roughly 8 days, allowing the initiation of the illness. So again, things that we need to take into perspective. It is a median of 4 days with a range of up to 14 days and can occur roughly over 8 days. And this is the transmission itself. So one of the things we need to take into perspective is how many days are people walking around with mild symptoms potentially spreading coronavirus to others. Studies have shown that asymptomatic transmission in people with no or minimal symptoms appears to be possible. We are now thinking that this is the major mechanism of disease transmission, which would aggravate any attempt to contain the spread of the disease. Another thing we need to understand is that patients may stay positive or have positive PCRs for weeks after their recovery. Think about that. You still have a positive coronavirus test for weeks after you've recovered from your signs and symptoms. Virus culture models are unable to recover viable virus after 8 days of clinical illness in patients with mild symptoms. Those of you that know me know that I'm a huge numbers and data nerd. I constantly tell people, hey, you're pushing this stuff out. Give me the citations, give me the numbers, prove and 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 back up um, the science that you're telling me. So one of the first things that I wanted to know is how does a county, how does a state, how does a country determine whether or not we should go into quarantine? Well, the way they do that is by determining the infection rate, something called the R naught. The R naught is the average number of people that an infected person transmits the virus to. Within this, we need to include the virus itself and the human behavior. So, if the R naught is less than 1, the epidemic will burn out. If the R naught is equal to 1, the epidemic will continue at a steady pace. If the R naught is greater than 1, the epidemic will increase exponentially. When COVID-19 first came into play at the beginning of the year, I honestly was one of those guys that said, should I be worried about COVID-19? Do I need to be worried about COVID-19? The numbers, the data shows at the time that COVID-19 actually was no different than seasonal flu. Over time, I asked numerous emergency room doctors, hey, should I be worried about this? And their first initial reaction without any hesitation was, yes, you should. So is COVID-19 any different than the seasonal flu? Well, let's go ahead and look at the R naught. The R naught for SARS-CoV-2 or the coronavirus is somewhere between 2.5 to 2.9. Some current studies have it as high as 5.7. So remember, right now we're looking at a median average of 2.5 to 2.9 with just a high level as 5.7. Taking things into perspective, H1N1 had an R naught of 1.4 to 1.6. The Spanish flu, 1.4 to 2.8. And here comes the kicker, guys. Seasonal flu has an R naught of 1.3. So the question I beg to ask is COVID-19 any different than the seasonal flu? I think we all know the answer to that now. So now let's look at the stats. As of 7/28/2020 at 16:35 p.m., the total global cases, confirmed cases of COVID-19 was 16,605,067. Confirmed cases by country, the US led the way. We had 4,341,201 confirmed cases of COVID-19. Globally, we've had 657,643 deaths, of which 149,052 deaths occurred in the US. In the state of Texas, according to the Texas DSHS dashboard, 7/28/2020, there was 143,939 active cases, 244,449 recoveries, 5,877 deaths, 9,593 current hospitalizations, of which 3,193 were ICU hospitalizations. A question I want you to ask yourself is, which number is the most important number? the active cases, the recoveries, the deaths, or the hospitalizations. Personally, I always look at the current hospitalizations, especially the current ICU hospitalizations, and definitely the number of deaths. Active cases can be a skewed number. Again, very controversial. We're kind of bordering on controversy here, but the active cases can be skewed. I've seen numerous patients, same people, that will go test at testing sites locally in the region up to 2 or 3 times a week. Again, being a data guy, I actually also look at the curve, or what we call the curve. From the beginning of March to current time in July, globally, the curve continues to increase. In the state of Texas, it continues to do the same thing. So, what's the deal with testing? Well, testing, it depends. There's a COVID-19 PCR testing. There's a viral test. The viral test tells you if you have a current infection. The viral test itself has a high specificity with an 80% sensitivity. The antibody test might tell you if you've had past infection. Usually this is done after full recovery. Remember that timing and the type of antibody test affects the accuracy of this result. Currently, the antigen test is the most reliable test available. So again, going back to controversies and social media controversies, um, and the fact of false negatives or false positives, COVID-19 PCR depends on obtaining a sufficiently deep specimen. Poor technique will cause the PCR test to underperform, thus giving you a potential false negative. COVID-19 is a spectrum of illness. Sicker patients with higher viral loads or viral burdens may be more likely to have a positive test. Likewise, sampling early in the disease may reveal a lower sensitivity than sampling later in the disease. The good thing about these exams is that the specificity seems to be relatively high, although contamination can cause false positive results. Once again, sensitivity is only about 80%. What about timing? What about time of testing? Antibody tests, the molecular test, can sometimes be acquired in minutes up to 2 days. The antigen test, usually you receive the results in minutes. It's less sensitive, but it's more accurate. A question that always comes up is, what should I use for PPE? Well, it depends. Do you have a COVID positive patient? Do you have a suspected COVID positive patient? Or do you have a COVID negative patient? For this purpose, any patient that is suspected of having COVID-19 should be treated as COVID positive. So you should have, at a minimum, a waterproof gown or a Tyvek suit, some sort of mask, either an N95 mask or a PAPR, a powered air purifying respirator. The patient should have a surgical mask on if they're not undergoing aerosol generating procedures. You should have a set of full goggles or some type of face shield. Hair covers recommended for aerosol generating procedures only. As you see in the picture, both medics in this picture don't have hair covers. A hood could be preferred if you're doing aerosol generating procedures, especially if you're doing an intubation. Shoe covers are not recommended, as removing them may cause exposure. Shoes that are easily cleaned and do not need to be touched are preferable in this type of situation. The other thing you should do with these shoes is you should spray them with 70% alcohol across the top, on the sides, and then the bottom of the shoes. Finally, you should also be wearing gloves. For the non-COVID patient, use your usual PPE. Place a mask on the patient, surgical mask, place a mask on yourself, wear some eye shields, a set of gloves, and it is preferred that you do not have direct face-to-face interaction with this patient. Stand off to the side. Some other infection control rules to live by. Pay attention to the junction between gloves and gowns. The gown should be tucked into the gloves, leaving no gap in between. When removing your PPE, always start by first applying alcohol-based hand sanitizer to your gloves. After fully removing the PPE, sanitize your hands and wrists with alcohol-based hand sanitizer again, and try to wash your hands as soon as possible. It is important that as an agency or a facility that you create a stepwise protocol for PPE removal and for donning PPE or placing PPE on. Consider doffing with someone watching you. This will ensure good, proper technique. Now let's look at the signs and symptoms of COVID-19. Typically, COVID-19 may cause a group of symptoms, usually an upper and lower respiratory symptom, and less commonly gastrointestinal system. Most patients will present with a group of symptoms and lower respiratory symptoms such as a fever, a dry cough, a runny nose. In 30 to 50% of patients, fever was present. The absence of a fever does not exclude COVID-19 though. Up to 10 to 20% of patients can present initially with gastrointestinal symptoms, i.e. diarrhea, nausea, vomiting, which precedes the development of a fever and dyspnea. Finally, if we remember our stages of the illness, a lot of these patients will be calling 911 or presenting to the hospital during stage 2. As a result, some patients will develop hypoxemia and respiratory failure without dyspnea, especially in the elderly. This is known as silent hypoxemia. The evolution of COVID-19 as a disease may be variable. Some patients are stable for several days after admission, but subsequently deteriorate rapidly. Ideally, most patients will present with dyspnea 6 days after their exposure. They will seek admission or call 911 8 days post-exposure and may possibly be admitted to the ICU or become intubated 10 days past the exposure. Again, these are variable. Some patients can stay stable for several days during this disease process. Prior to the discussion of the treatment of COVID-19 patients, it is important that you understand that you must use your agency or facility's COGs, protocols, or SOPs for the treatment of your patients. The current section will cover the aggregated treatments and current evidence-based medicine that I have researched over the last few months. Treatment modalities will be presented to you along with the stages of the infection. So stage 1, early infection. Usually the patient needs to seek self-treatment of their symptoms and self-isolate themselves. This is the only treatment that is needed for these types of patients. Also, they must monitor themselves for hypoxemia, increasing shortness of breath, difficulty walking, difficulty catching their breath. If you do see a patient with hypovolemia or the beginning stages of shock, it is important to understand that IV fluid resuscitation should generally be avoided. For patients with a history of diarrhea, clinical evidence of hypovolemia, it is important that we titrate fluid administration, that we titrate it to try to maintain a MAP of 60 to 65 millimeters of mercury. If you have attempted to give conservative IV fluid to these patients and it doesn't work, you may consider norepinephrine 2 to 20 micrograms per minute or a push pressor as indicated. Again, follow your agency or facility guidelines. If the patient is experiencing significant dyspnea or hypoxemia, try to stabilize them with the following techniques, and preferably in this order. For patients with significant dyspnea or hypoxemia, provide low-flow nasal cannula at 2 to 6 liters per minute. Consider using awake proning with or without high-flow nasal cannula at 40 to 60 liters per minute. Know that most agencies are not equipped for high-flow nasal cannula. If the patient is still complaining of significant dyspnea or experience significant dyspnea, consider CPAP or BiPAP with high levels of end expiratory pressure. I cannot stress, when in doubt, err on the side of avoiding intubation. That is the last thing that we want to do. For patients also experiencing severe hypoxemia, some of the medications that we could potentially use for them are an MDI with a spacer. Give about 3 to 5 puffs. Don't use nebulizer treatments and do not use the MDI. Typically, we will give the MDI and the spacer to the patient to take with them to the hospital. Consider terbutaline 0.25 milligrams sub-Q or IM every 15 minutes, mag sulfate 2 grams IV over 20 minutes, and even consider epinephrine 1 milligram per ml of the 1 to 1,000, but understand that it may exacerbate any potential cardiac dysrhythmias. Once again, please follow your SOGs, SOPs, or protocols that are provided to you by your facility or agency. Stage 2 in the pulmonary phase. It is important, again, and I'm using this word important over and over and over, I know that you try to avoid intubation at all costs. Starting supplemental oxygen is recommended if the SpO2 is less than 90%. SpO2 should be maintained no higher than 96%. The way you're going to do this is you will provide low flow oxygen at 2 to 6 liters per minute via nasal cannula. For acute hypoxemic respiratory failure despite conventional oxygen therapy, consider the use, once again, of high-flow nasal cannula. Again, your agency or facility may not have this capability. Close monitoring for worsening of respiratory status and early intubation, if worsening occurs, is recommended. This is basically best practice. If you have the capability, CPAP or BiPAP with high PEEP has been shown to provide marked improvement for these patients in respiratory distress. For adults receiving mechanical ventilation who have acute respiratory distress syndrome, it is recommended that you use low tidal volume ventilation, usually 4 to 8 mLs per kilogram of predicted body weight. It's recommended and preferred over higher tidal volumes, usually anything over 8 mLs per kilogram. Some medications to consider for the patient in the pulmonary phase. Again, an MDI with a spacer, usually 3 to 5 puffs, is equivalent to 1 albuterol nebulizer treatment. Terbutaline 0.25 milligrams sub-Q IM every 15 minutes. Magnesium sulfate 2 grams IV over 20 minutes, and potentially epinephrine 1 milligram per ml. But again, remember that this may exacerbate cardiac dysrhythmias. For patients that present febrile with a fever, consider using acetaminophen 500 milligrams to 1,000 or 1 gram PO, ketorolac 15 milligrams IV IM, or orformev 15 milligrams per kilogram IV over 15 minutes. For patients experiencing severe pain, also consider any of the above mentioned medications. Another medication to consider, fentanyl, 0.5 to 3 micrograms per kilogram IV, morphine sulfate, 4 to 20 milligrams IV, or ketamine, 0.3 milligrams per kilogram IV. Please consider non-opiate pain control measures first. For sedation, especially in an ICU setting, consider propofol 0, this is what the range said, 0 to 30 micrograms per kilogram per minute. So here's the general schema for respiratory support in patients with COVID-19. Looking at one side, which is deterioration versus the recovery from it. The optimal strategy for respiratory support in the COVID-19 patient remains unknown. Patients with more complex respiratory disease might benefit from BiPAP. The choice of CPAP versus high-flow nasal cannula may vary depending on the resources and the patient preference. COVID-19 appears to cause progressive microatelectasis, which responds well to CPAP. So, low-flow nasal cannula, typically set at 1 to 6 liters per minute. If that doesn't work, consider high-flow nasal cannula or CPAP. If that doesn't work, move over to awake pronation plus CPAP. We have actually had a case with one of our EMS agencies where they provided high flow nasal cannula with awake pronation, and the patient did seem to improve during the transport time. Invasive mechanical ventilation is next, along with prone positioning. And finally, one of the things that we will not really go into detail with in this lecture is ECMO. Once again, I am reminding you to use your local protocol, COG, or SOPs provided to you for COVID-19 patients by your facility or agency. Stage 3, hyperinflammation phase or the cytokine storm. IV, again, IV fluid resuscitation should generally be avoided. In hypovolemic patients, they should receive conservative amounts of IV fluid. Severe hypotension or shock, consider again norepinephrine 2 to 20 micrograms per minute or push pressor as indicated. Ultimately, what you want to do is you want to maintain a MAP of 60 to 65 millimeters of mercury. How about antibiotics? Again, it's something to kind of look at. Antibiotics are not going to be the game changer. Do not withhold any other type of care in order to give the antibiotics. If you suspect sepsis, especially as a result of a secondary bacterial infection, consider using empirical antibiotics. We all like pictures, we all like graphs, so here's the treatment modality and some of the treatment plans in that type of form. Stage 1, the early infection. Stage 2, pulmonary phase. This is the viral response phase. Stage 2 and stage 3 is now a host inflammatory response phase. So we look at some clinical symptoms. In the stage 1, mild constitutional symptoms, a fever greater than 99.6, dry cough, diarrhea, headache. Stage 2, shortness of breath, hypoxia with a PaO2 and FiO2 of less than or equal to 300 millimeters of mercury. Stage 3, acute respiratory distress syndrome, systemic inflammatory response syndrome, shock, cardiac failure. On the bottom, you look at some potential therapies. We'll discuss these therapies shortly. So, what about antivirals and steroidals? Treatments regarding antivirals remain pretty controversial as more studies are being conducted. Each study needs to be taken into perspective. Again, this is a very controversial topic. Again, we've seen it in social media, we've seen it on the news, we've probably had these discussions back and forth amongst ourselves. It is important that you look at the studies. It is important that each study be taken into perspective. Things that need to be looked at: the size of the study group. We must also look at the qualifying factors of the participants in these trials. Trial number 1 regarding hydroxychloroquine. Alexandra B. Cavalcanti. Among 667 patients hospitalized with mild to moderate COVID-19, the use of the antiviral hydroxychloroquine alone or with azithromycin did not improve clinical status at 15 days as compared with standard care. A second study, the Henry Ford study from July 2020. In a large-scale, non-randomized, retrospective analysis of 2,541 patients hospitalized between March 10th and May 2nd, 2020, across the system's 6 hospitals, the study found 13% of those treated with hydroxychloroquine alone died compared to 26.4% not treated with hydroxychloroquine. Again, this was patients that were severely ill. The recovery study from June 2020, a total of 1,542 patients were randomized to hydroxychloroquine and compared with 3,132 patients randomized to usual care alone. There was no significant difference in the primary endpoint of 28-day mortality, 25.7% hydroxychloroquine versus 23.5% usual care. Studies regarding the antiviral remdesivir. John H. Bagel et al., May 2020. Remdesivir was superior to placebo in shortening the recovery time in adults hospitalized with COVID-19 and evidence of lower respiratory tract infection. The SIMPLE trial, performed by Gilead Sciences Incorporated, the maker of remdesivir. A 5-day treatment course of remdesivir resulted in significantly greater clinical improvement versus treatment with standard of care alone. I looked at these studies and researched them numerous times in numerous ways. The take home from this was basically this: for maximal benefit, antiviral therapy needs to be started very early after the initial development of symptoms or during the viral phase. To date, evidence with numerous antiviral therapies has proven to be somewhat disappointing. Overall, the use of antiviral therapy for critically ill patients appears to be limited right now. What about steroids? So steroids are not recommended in patients with normal oxygenation. The indications for steroids are pretty simple: acute hypoxic failure, requirement for mechanical ventilation, and other accepted indications for steroid use: COVID with asthma, COVID with COPD. The recommended dosage and steroid is dexamethasone 6 milligrams daily for 10 days or 32 milligrams of methylprednisolone solomedrol over the same time period. One of the largest trials that was done was the recovery trial. The recovery trial has shown in patients hospitalized with COVID-19, dexamethasone reduced 28-day mortality among those receiving invasive mechanical ventilation or oxygen at randomization, but not among patients not receiving respiratory support. I ask you guys to do one thing and to make your own conclusions. Read studies, read into the studies, look at the number of patients in the study, and look at the control groups in the study. Once you've looked at this, you'll be able to make a informed, educated decision as to whether to use antivirals and steroidals and when to use them. As we approach the end of our presentation, I want you guys to kind of look at a couple of things. Number one, complete a full physical assessment and history before assuming that the patient has COVID-19. It may not be COVID-19. Remember that patients are rarely in shock on admission or during transport or EMS transport. Even among critically ill patients, admission blood pressure is generally normal and lactate elevations are mild to moderate. Overall, the rate of reported sepsis is generally low, less than 5%. The virus does not seem to generally cause a septic shock picture, but of course, patients may always suffer from superimposed bacterial septic shock. At the time of this presentation, the cause of death from COVID-19 is nearly always ARDS, which may be exacerbated by fluid administration. So again, gentle fluid administration could be considered for patients with evidence of hypoperfusion and a history suggestive of total body hypovolemia, prolonged nausea, vomiting, diarrhea. In a patient with COVID-19, elevated troponin levels is normal, and it's usually a strong predictor of mortality. On 12-lead EKGs, elevated ST segments may be seen due to endocarditis, cardiomyopathy, myocarditis, and pericarditis. So please make sure that you acquire a 12-lead EKG on these patients. Currently, besides ARDS, cardiogenic shock appears to be an important cause of death in our patients. Remember to avoid intubation. Patients that are not intubated have a subsequently better prognosis for recovery. Before intubation, I want everyone to consider some key factors. How is the patient oxygenating? How is their work of breathing? And what does their clinical trajectory look like? Before you decide to intubate these patients, consider CPAP, usually at 15 to 18 centimeters of water if tolerated. If you have chosen to intubate this patient, remember that the risk of infection is extremely high or relatively high for the provider. Right now, studies show that 1 in 10 providers will acquire COVID-19 after intubation of a patient. If you are providing ventilatory support, have a patient on mechanical ventilation, make sure that you are using a viral HEPA filter, and it should always be used to create a closed system with these types of patients. I want everybody to know that I greatly appreciate everything that every single one of you frontline providers have done. I have people that sit there and say, this scar on my face or this scar on my nose, I don't think it's ever going to go away. My response to them is simple. Wear the scars as a badge of courage. Years from now, people will know what you sacrificed in order to save the world. Thank you for the great job that you do. Thank you for continuing to sacrifice yourself and to sacrifice the time that you spend with your family in order to keep others in need. As we conclude this presentation, remember that we continue to learn more about COVID-19 every day. The things that we did 3 months ago are not the same things that we did 3 days ago. The things that we did 3 days ago are probably not going to be the same things that we do 3 months from now. Stay informed, follow current evidence-based practices, and question treatments and data by asking for references and citations. We will only continue to learn more about this disease by keeping ourselves informed. You may now continue on to the quiz so that you can get your continuing education credit for this class. Thank you. Everyone stay safe. Have a good day.